If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome, I'm Fernando, a GP in the UK. Today we're going to cover what to do when we encounter an isolated high bilirubin with otherwise normal liver function tests, always focusing on what is relevant in primary care only. This episode is based on the British Society of Gastroenterology guidelines on abnormal liver function tests. A link to it is in the episode description. Right, let's jump into it. And let's start by remembering that there are three common patterns of abnormal liver function tests, or LFTs. An isolated raised bilirubin with otherwise normal liver function tests, which is what we will concentrate on today. A cholestatic pattern, normally showing a high alkaline phosphatase and gamma-GT, and a hepatitic pattern with a raised ALT and AST indicating hepatocellular injury. By the way, if you're interested in finding out more about this particular type, make sure to watch the corresponding episode on this channel. The link is in the episode description. By going back to the high bilirubin, let's also remember that bilirubin is the byproduct of the breakdown of hemoglobin. When red blood cells are broken down, bilirubin is produced and released into the bloodstream. It exists in two forms, unconjugated bilirubin and conjugated bilirubin. Unconjugated bilirubin is water insoluble and travels to the liver bound to albumin. Once in the liver, it is converted into conjugated bilirubin, making it water-soluble so it can be excreted into bile. A high unconjugated bilirubin level is usually due to increased production, as in hemolysis, or reduced conjugation within the liver. A high conjugated bilirubin, on the other hand, is normally due to liver disease or biliary obstruction, where the liver is unable to process or excrete bilirubin normally. Many path labs will routinely report only the total bilirubin, but they will provide a breakdown into conjugated and unconjugated fractions if the level is abnormal or if it is specifically requested. Under normal circumstances, the majority of bilirubin should be conjugated. Therefore, if most of the bilirubin is unconjugated and there is no evidence of hemolysis, the cause is almost always Gilbert syndrome. In Gilbert syndrome, the enzyme responsible for conjugating bilirubin has reduced activity. As a result, unconjugated bilirubin accumulates, often fluctuating with fasting, stress, illness or dehydration. Importantly, it is not associated with liver disease or ill health, and patients should be fully reassured that it is a benign lifelong condition. But we will come back to that a little later. How do we manage patients with a high bilirubin? When we manage patients with any abnormal liver function tests, we must start by recognizing red flags that require urgent action. According to the British Society of Gastroenterology guidelines, if there are signs of synthetic liver failure, for example, unexplained clinical jaundice or low albumin, or a raised INR, or if there is suspicion of malignancy, such as unexplained weight loss or marked cholestasis, then these patients should be urgently referred or admitted for specialist assessment. For patients whose only abnormality is an isolated raised bilirubin and who have no worrying clinical signs, we can follow a more measured primary care approach. First, we will request a full blood count and repeat liver function tests on a fasting sample, asking specifically for the breakdown of conjugated and unconjugated bilirubin. The repeat sample should be fasting because in conditions like Gilbert syndrome, the unconjugated bilirubin tends to rise further when the liver's conjugating capacity is challenged. So, why does fasting raise bilirubin in Gilbert syndrome? Firstly, because there is reduced hepatic energy availability. During fasting, blood glucose levels fall and the liver prioritizes essential metabolic functions. Bilirubin conjugation is not a high priority process, so the already reduced enzyme activity present in Gilbert syndrome becomes even less effective. Secondly, there is increased bilirubin production because fasting slightly increases the breakdown of hemoglobin and other heme-containing proteins, increasing bilirubin entering the system. And thirdly, there is reduced hepatic uptake of bilirubin from the bloodstream because of changes in liver blood flow and transporter activity. If after the repeat sample the unconjugated bilirubin rises further on a fasting sample, and there is no evidence of hemolysis, for example no anemia, then Gilbert syndrome is the most likely diagnosis. The British Society of Gastroenterology guidelines emphasize that for the pattern of isolated raised bilirubin with otherwise normal liver tests, Gilbert syndrome is the most common cause. If there is associated anemia, this should prompt consideration of hemolysis rather than Gilbert's. In that scenario, we should request a reticulocyte count, an LDH, and possibly haptoglobin. This is because when hemolysis occurs, red blood cells are broken down more quickly than normal. This increased red cell turnover releases large amounts of hemoglobin, which is then converted into unconjugated bilirubin. As a result, the unconjugated bilirubin rises in the bloodstream. To confirm hemolysis, we check a reticulocyte count, which will be high because the bone marrow is trying to replace the destroyed red cells. An LDH, which is released from damaged red cells and therefore increases too. If available in primary care, we may also check haptoglobin, which binds free hemoglobin and becomes low when hemolysis is present. If hemolysis is suspected, the patient should be referred to a hematologist because hemolysis can have many underlying causes, and diagnosing the exact cause requires specialist tests that are not usually available in primary care. However, if the isolated raised bilirubin persists and the cause remains unclear, or if any additional liver function test abnormalities emerge, then we should follow the British Society of Gastroenterology guideline recommendations for further investigation. This may mean following the pathway for a hepatitic pattern or a cholestatic pattern, depending on the case. But in any event, we should consider a liver ultrasound scan to exclude biliary obstruction or structural liver disease. We will also consider a full liver screen. And what is a full liver screen? Apart from the ultrasound scan already mentioned, this should include hepatitis B and C screening, an autoantibody screen, serum immunoglobulins, both ferritins and transferrin saturation, and often a celiac screen, alpha-1 antitrypsin levels, and ceruloplasmin. And finally, we should also consider rechecking whether there is any evidence of hemolysis by repeating the reticulocyte count and LDH if hemolysis is still suspected. And eventually, the decision will be between monitoring versus referral. If after all the above investigations the clinical picture remains consistent with Gilbert syndrome, we can continue with periodic monitoring in primary care. On the other hand, if the isolated raised bilirubin is persistent and unexplained, we should refer the patient for specialist assessment. So that is it, a review of what to do when we encounter an isolated raised bilirubin with otherwise normal liver function tests. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening, and goodbye.